Welcome, CHEKITAAN. So, CHEKITAAN would be speaking on OCTA simplifying my decision making in ARMD.
So, good afternoon, everyone. So, as a part of the instruction course, I'll just try to highlight certain areas which will, where the OCT did it simplify my decision making or did it confuse me even more. So, OCT versus FFA and ICG, the debate rages on. So, FFA images, advantages of OCTA are that FFA images are single plane. It gives you only shows you one plane. However, OCTA images give you a 3D view. It shows you all the planes, superficial plexus, deep capillary plexus, choriocapillaries, and outer choriocapillary layer and choroid. So better localization of vascular pathology is there. OCTA also has a higher resolution than your angiography machines, gives information about both structure and flow. That is another thing which you need to find out these days. It is super fast, it is non-invasive, no dyes involved, no allergic reactions. Image acquisition is much faster now. The earlier machines were slow, but these machines now are not slow at all. And they have a comparable sensitivity and specificity to FFA and ICG in CNV detection that is studied. Limitations are it is more sensitive to media opacities, more sensitive to eye movement, like sir just showed. Artifacts and segmentation errors can spoil your diagnosis and can confuse you. And it is a single snapshot in time of a retinal vasculature. There is no continued study, like the angiography continues for 10 minutes. So there is a temporal information which you get. You can distinguish between a leakage and a staining, so you don't find any of this on OCTA. And does not pick up slow flow lesions, especially a fibrotic CNVM. Microaneurysms, you will see very few of them on OCTA, and retinal artery macroaneurysms as well. So not the investigation of choice. This is the Angioplex 6000, which I have acquired since more than a year now. And it's a wonderful machine with 1 lakh A scans, as I told you, and a good resolution and quick speed. So aiding our treatment decisions, you can see this particular patient was a old CNVM. He had been injected many times, became symptomatic, came to our clinic. Mild decrease in vision, half a line, and you can see some intraretinal fluid here next to the CNVM, next to the raised lesion. You do angiography, doesn't really give you much information, just a little bit of staining around it, not much of an active leakage. But we do the OCTA, and you can beautifully see the choroidal neovascular membrane there. So it's a neovascular complex we decide to treat, and the patient becomes asymptomatic 1 month after a single anti-VEGF, and the vision improves. Another case is a fibrovascular PED. So nothing really informative on fluorescein angiography, but on OCT, if you see a neovascular complex and you see fluid here. And of course, a proper choroidal neovascular membrane with a halo around it, which indicates activity on a OCTA. So it nails the diagnosis, no more confusions, and you can inject. Another patient, a 65-year-old male, he was a doctor by profession, wanted cataract surgery. And I saw some RPE alterations at the macula. So we ordered OCT, and to my surprise, there was a peaked PED and some amount of SRF. So again, angiography was done, but did not reveal much information. It is, you cannot really treat based on this angiography. So we did a OCTA, and that is when you see a beautiful neovascular complex. And this is most likely a IPCV, so a branching vascular network here. We treated with 3 anti-VEGF, subsequently changed to Eylea, and the lesion has completely regressed now. So as Bruno Lombroso says, the main shortcoming of dye imaging is that it identifies exudation from a CNV and not the CNV itself. So it can lead to an indirect diagnosis and cause errors. Another area is PFT, of course not directly related to AMD. This was a 60-year-old lady with PFT, complained of metamorphopsia, did an angiography. And there is some leakage here, and you see a roughening of the RPE here. So you do a OCTA, and we are able to pick up a beautiful choroidal neovascular membrane here. And this is post-treatment. You can say this membrane has completely disappeared. That is how you follow patients post-treatment. And this is the best way to pick up that a CNVM has regressed. If you find a CNVM there 1 month after anti-VEGF, you don't find it. So it disappears completely in certain scenarios, not in all though. Again, a similar patient, 45-year-old lady, post-anti-VEGF, presented with metamorphopsia and some amount of subretinal fluid here you can see. Of course, the FFA is quite diagnostic in this. It is showing you the leakage, but it is the OCTA which shows you the membrane and gives you the confidence. You can see the beautiful membrane here, and this is after 3 anti-VEGFs. Now, what you see in regression is arterialization of the membrane. You will see more thicker blood vessels there. You will see the smaller blood vessels, smaller branches all going off. And the halo which was there, that also slowly goes off. That is how you see. And of course, you have to combine it with your clinical examination, which is equally important, and the OCT also. This is the left eye of the same patient, of course, after multiple anti-VEGFs. And you can see even the FAF is showing you that it is scarred on OCT, FFA, and even on the OCTA. You can see there is hardly a discernible membrane here. It is all a fibrotic area which is there. So it doesn't need treatment. Another, it tells us to wait in certain scenarios. This was a 70-year-old male, a father of a renowned ophthalmologist, got operated and presented to me late when he had a CNVM. It was a PFT, and we gave him 3 Eylea, and vision improved from counting finger to 6/24. You can see on fundus autofluorescence a scarred lesion. And this was his right eye. So he was very scared to get operated in this eye because he thought the surgery caused the CNVM. And he had RPE alterations here, of course seen on FAF. And once we did the OCT, we found some RPE undulation here and flattening of the contour. So we did an angiography, again confusion, you really can't treat or wait based on this angiography. So we did a OCTA, and you can pick up a membrane here. But as I told you, this is a non-exudative CNVM. There is no SRF, and you're not picking up a proper neovascular complex on OCT. So we decided to wait, although his other eye had a bad outcome, but still we decided to wait. And this you can see was in August, and this is in February. So he's on monthly follow-up, and this is the only test we do. We do a OCT and OCTA, and we keep seeing the membrane, and you can see there's hardly been any change. Of course, you need to know that there is a 10 to 15 times risk of conversion of a non-exudative membrane to a exudative membrane, and the PROCON study says around 29% risk of conversion to wet AMD by 2 years. So we need to follow up these patients, but of course, PROCON was to study whether aflibercept helped in prevention of conversion of non-exudative to exudative. It did not. So if you keep giving injections seeing a non-exudative membrane, that's not a good idea. So you should wait. But as and when I will see that this membrane will become bigger or new shoots will come, even if I don't see SRF on, on the OCT and the patient becomes symptomatic, I can treat earlier. Then I would treat in the earlier times. Again, an area which leads to a lot of artifacts is geographic atrophy. And if you have a small CNVM with this, you cannot pick it up. This is a large area of geographic atrophy. You can see the lipofuscin, pigments on fundus autofluorescence, and extremely thinned out choriocapillary complex. And once you do a OCTA, you cannot figure out anything. This is because of transmission artifacts, and so you are not able to really pick up any CNVMs or anything in such areas. So this is one area where there is a limitation because of the choroidal vasculature and the superficial plexus. They both fuse together, so you're not able to really pick up anything. Another area which the OCTA doesn't help is in large PEDs. This is a gentleman, 70-year-old gentleman, presented with a huge PED at the macula with 6/9 vision. He has 6/9 vision in this eye, and you can see on fundus autofluorescence the extent of that. And this is the fluorescein angiography. You can see some activity here, and of course in the PED. This is PED measures around 1100 microns, which I measured it with some activity here. And on OCTA also not really giving you too much information, as to whether you should treat, not treat. So for these, of course, you go for ICGA, and these in most chances can be a IPCV as well. You just get some activity here, but nothing very characteristic. So in conclusion, it's a very exciting and useful technology, has the potential to replace angiography in the coming times. More wide field image acquisition will boost diagnostics, even for uveitis cases. A compact, powerful, ergonomic, fast and multi-dimensional machines backed with a great software are the future. Thank you for your patient hearing. Any questions?
Doesn't come completely go away after injections?
Yes. I think we are not aiming for the disappearance of a CNVM, but if it does, BVNs can disappear, especially in polyps. So when you're giving that, a disappearance indicates that the drug is working. So, if your injection, there is not much change in morphology in a CNVM, you have injected anti-VEGF, that also tells you maybe an indicator of resistance, to this thing. So it doesn't disappear. It becomes arterialized, the vessels become thicker, the branches reduce, that is how you pick up changes.
So how do we really follow up? It may recur or it has recurred.
I think follow-up is monthly most of the times. Monthly you do it. Certain times when the visual acuity is absolutely stable, you might only do a OCT. And, if the patient can afford, you can do OCTA maybe 2 monthly, something like that. So it depends on the patient's affordability. But most of our treatment regimens, I don't think are I would say, PRN. So, when you really require...
Treat and extend
yes, you'll give,
I think what you wanted to ask about the sign of activity on a follow-up reactivation. So on OCTA, the most sensitive is appearance of new loops. So if you get that new loop vessels surrounding that membrane, because as he rightly said, these become more elongated vessels, more mature vessels, that means it is acting. Suddenly if you see immature small loops, these are sign of activity. However, in clinical practice, you don't only rely on new loops. Many times you look for appearance of a new hemorrhage, fluid, exudate, or in a structural OCT presence of fluid. But besides that, added thing from OCTA is a new loop.
What would be the difference between Plexilite and Cedar 6000? Would media opacity be less important? You would have used both the machines.
Both the machines we have used, to be very true, for posterior pole lesion doesn't matter much. It is not that much difference for posterior pole. The main advantage of using Plexilite is the mid-periphery periphery seeing till 12 millimeter, 16 millimeter. But posterior pole 3x3, even with the angioplex, you get fairly good. The other advantage of angioplex is it has got already the metrics, if you want to do quantitative vessel densities, which are already there. Plexilite is a platform, so you don't get any quantitative measurements. You want to use, you have to upload it, and then the company gives back the thing. That has got already the metrics for all angiometrics, which you don't get with Plexilite presently.
It's like your normal OCT. So it will not take much time. You don't have to feed anything anywhere. And it gives you a number of A scans which is comparable to a SSOCT, of course. And it gives you HD and everything, HD angiography as well, HD OCTA. So it doesn't take any more extra time. That is what I wanted to tell you. There are certain machines in which you struggle to even see the choroidal neovascular membrane. You have to manually sit and segment, nothing all that. All the artifacts, all the projection things are removed, and then you get the report. So that helps.
I think the lesson is what I was showing. Many times you may miss those membranes if there is not a proper segmentation, because with disease pathology, the segmentation may vary. It's important to look at the whole scan as a video, like all the things. You'll definitely not miss it. I think do that.
And all the layers, when you see, like I showed you, there are some 5-6 layers. So you should go and individually see. And individually, when you click on the layer, you can go up and down. You can move the cursor and, you can still segment if you want.